and welcome to Pharmacy Internet Radio, also known as Pharmacy IR. I am one of your hosts, Kat Collins, and I'm joined by Dr. Scott Perkins. How are you doing today?
I'm doing well. How are you doing?
Doing good. Yeah,
Good.
I heard you just got back from Spain.
I did. I spent 7 days there in Barcelona and Madrid. Walked around a bunch, dodged some rain when I could. But it was beautiful.
Yeah.
My hip's hurting.
More beautiful than Buies Creek?
Slightly. Slightly. Actually, it's very similar.
Okay.
Very similar.
Well, I don't need to go then. I'll just...
Yeah.
I'm basically in Spain right now.
Yeah, you can probably take an Instagram photo out there. I'm sure you can fool everybody.
Okay.
Yeah, right next to the little fire that's going on.
Yeah.
Walked around a lot, hurt my hip a little bit, but I'm glad to be back. Rest up, get my hip feeling better. Now you've got some things going on your plate.
Yeah, I'm glad to be leaving.
Yeah, you're about to get out of here.
I got about one day left of class for my entire life, so
That's awesome.
I'm looking forward to that.
Yeah, no extra degrees. You're done.
No, I think I'm done. 3 degrees enough. But this will be our last podcast for the semester.
Yeah, that's true. That's true.
Yeah.
So with that in mind, we do have a survey in the description of the video. So we'd like to get some feedback to help improve it going forward after the semester is over and done with. To schedule new interviewees, to schedule new segments, to just make it more worth their time to watch. So without further ado, we'll jump into our interview with Dr. Muzyk.
Alrighty. Hi, I'm Kat Collins. Welcome back to the Pharmacy IR interview. Today we are joined by Dr. Andrew Muzyk. And Dr. Muzyk is a faculty member at Campbell University in the Pharmacy Practice Department, and he is also a faculty member at Duke University School of Medicine. Dr. Muzyk is an internal medicine and psychiatric pharmacy specialist at Duke University and precepts students from Campbell University. Hi, Dr. Muzyk. Thanks so much for joining us today. So tell me a little bit about your background, how you grew up, and how you got into pharmacy.
Okay, so how far do you want to go back?
As far as you'll take us.
I feel like we need a couch instead of a chair.
Yeah.
So I grew up in a little small town called Brandon, Florida, which is outside of Tampa, Florida, right there on the west coast of Florida there. And so I went to the University of Florida for undergrad, and then after that I joined my sister in pharmacy school at Mercer University in Atlanta. But so I joined her. She was at Mercer, and so I joined her up there at pharmacy school, and spent 4 years there at Mercer. And then after Mercer, I went ahead and did 2 years of residency. My first one was in just a general PGY1 residency program in Alabama, in Tuscaloosa. And then after that, I went over to the University of North Carolina, and that's where I did my second year of residency, which was focused in psychiatry. And then after that, I spent a little time at Dorothea Dix. I think it was about 3-4 months or so at Dorothea Dix Hospital before everything kind of shut down at Dorothea Dix and at John Umstead, and they merged those two hospitals into what's now Central Regional Hospital. And so as I started my job there at Dorothea Dix, the plans were already in place to move everybody out of the hospital and move them over to Central Regional Hospital. And so programs like UNC and Duke were also starting to leave the hospital. And so I think that's when I got the call from some folks here at Campbell about coming and joining them on faculty in this position where I'm here on faculty here at Campbell. But I spent a lot of my time at Duke University Hospital, where I round on the medicine psychiatry treatment team and take fourth-year students on that rotation, as well as on a psychiatry rotation. And then in addition to my teaching responsibilities at Campbell and precepting, I also do a fair amount of research, and a lot of it is directed toward educational research, and then looking at kind of hospital-based research in psychiatry and addiction. So, and then over this is coming on to my 12th year now of having been on faculty. I've done a fair amount of research looking at some hospital-related outcomes to how we use medications. And then just in the past several years, I've been doing a lot of educational research. So really talking to students, trying to understand how we can best educate them about psychiatry and about substance use disorders, and really do it in an interprofessional way. So bringing in pharmacy students and having them work with the medical students and the nursing students, social work students from UNC and NC State, and then also our physician assistant students at Duke. So not only is there like different health profession students, but they're also coming in from different programs across Central North Carolina. So it's been a really really cool experience.
Great.
Yeah.
So what exactly made you first interested in pharmacy, or was it?
Yeah, yeah. Well, I'd love to say that like I've always had this like burning passion to be a pharmacist, but the reality is that's not true. I was kind of at University of Florida, kind of found my footing, was doing a lot better in the prereq science classes, was starting to kind of get some good momentum there, and my sister, who was already at Mercer, I think in her second year at that point, or third year at Mercer, she was like, I'm here. It's pretty cool. You're doing well in some of these classes that you need to do well in pharmacy school. It's in Atlanta. I never lived in a big city before that. So she was like, you should think about joining me. And my parents also too were pushing me toward it's time for you to make a decision, Yeah. As I was getting in my second or third year of undergrad. And so they were asking me to kind of think about what it is I wanted to do. And my sister had already paved the path. And she was at Mercer and doing well there. And so I just was like, okay, I'll just go join you. I don't know, leap of faith. And so I joined my sister, and not really knowing much about pharmacy, I'll be honest. I'd never worked in a retail setting. I think I did some volunteer work at an indigent clinic. So I did some of that. So I had some experience with working with a pharmacist and pharmacy technicians, but I really didn't know much about it. And so I just joined my sister. And then when I got to pharmacy school is really where I found that, how much I enjoyed being in school. And I'm sure your next question is going to come, how did I get into psychiatry? And so that's what happened. Like my second year is when I started learning about the medications, their mechanism of action, started learning about the pathophysiology of the diseases. So learning about things like schizophrenia and depression, substance use disorders. Third year, learned how we used medications to treat them. And so like each year, subsequent year, I just got more and more interested in it. And then on my fourth year, when I believe I did 2 or 3 rotations in a psychiatric facility and a detox facility as well. I think I did inpatient, outpatient, and then a detox facility, and I just loved it. I thought it was great. I loved the drugs prior to going into those rotations, really loved understanding the pathophysiology, and then when I started working with the patients, that's really where I was like, it all kind of came together, and I was like, this is really cool, really interesting, and the patients have these stories that to me are very interesting stories, and certainly it's a vulnerable patient population, and so that kind of feeds into it as well. But yeah, I don't think in the 12, probably the 14 years now that I've been out of school and working in psychiatry in an addiction in that area that I've ever said like, I don't like this, or like I made the wrong decision. I think every day I'm kind of like, it's pretty cool. Like there's some cool stuff that goes on, and at Duke, at the hospital, being on a medicine psychiatry service, we see stuff that like I haven't seen in a long time, or haven't seen ever. Or it's like the 1% of stuff that you read about with an adverse reaction with a medication, or 1% of 1% of 1% of something that you see a patient present with. And it's really, it's really pretty interesting stuff. So yeah, I've never at any point said like, hey, this is boring. Like there's nothing else for me to do. I'm no longer interested in doing this kind of stuff. So. Yeah. So
who was Dr. Muzyk the student, and what kind of organizations were you involved in?
So as a pharmacy student, grade-wise, I was a great student. I did really well in pharmacy school, GPA-wise, and all that stuff. I think if you were to ask like the faculty, was I like a great student, they would probably say no, in that I really wasn't that involved. I was involved in a couple of organizations, one of which was the College of Psychiatric and Neurological Pharmacists, or CPNP, which was the one that just obviously caught my attention. There were a couple of faculty at Mercer who were heavily involved in that organization, and they kind of pulled me right into it. So that was the one that I was involved in, and then in the Rho Chi fraternity as well. But outside of that, I don't really remember being that involved, which is unfortunate, and I probably should have been more involved and kind of opened myself up to different experiences and getting to know different students at Mercer across the different years there. As far as like, being a student, I just remember like studying a lot. And I studied on my own a lot. I wasn't always in class. I tell students all the time, you gotta come to class, especially my classes, because they're interactive, and you can't be interactive if there's no one there, or it's just me kind of in an echo chamber, just kind of saying my stuff out loud, instead of having it bounce off students and getting some of their feedback on it. But I spent a lot of time studying. I read DePiro probably from the first page to the last page, and then I also read Goodman and Gilman's. I forgot what that book is, what the title of that book is, but Goodman and Gilman is how I remember it. I read both of those books. pretty much from front to back cover. And I think that really just speaks to the fact that like I really do love pharmacology. I love understanding how these drugs work. I'm interested in the connection of pharmacology as it relates to both normal and abnormal behavior and brain development. And then DePiro really does tie it all together and talk about like here's a little bit of etiology, epidemiology, pathophysiology, but the main portion of the chapter is like how you actually therapeutically use these drugs. So I spent a lot of time, as I do now, a lot of evenings and weekends, like reading, and I also used to take like just a ridiculous amount of notes. I mean, it was like at times like the scribblings of a madman. I'm sure probably somebody was like, you need to go to one of these one of these units that you round on. But yeah, it was a lot of writing, it was a lot of reading, and then I just studied all the time. So.
Do you ever go back and look at the notes? Or do you
I would be afraid to. I'm sure I probably have them somewhere. But yeah, I don't know. I'd be afraid to go back.
So, if you could go back in time and talk to yourself as a student, what advice would you give yourself?
Yeah, I mean, I think, I guess the advice that I give students now is probably advice that I would give myself if I was going through the process again. And really some of the things that I felt that I had missed in undergrad as well as in pharmacy school and probably up to the past several years or so. But really just opening yourself up to experiences. You never know what it is that you're really going to relate to, and you're never going to know what it is that you relate to if you don't allow yourself to be open to different experiences. As I talk to students and I work with students, as I review applications, really what I look for in a student is just somebody who has life experience. And for somebody who's young, I mean, that means, there's not a lot of opportunities to have these really grand life experiences, but there are some. And so I always think that it's really cool when I look at applications where I talk to students and they've had something that's different and unique, and in some way that experience has helped them grow. Because talking to them, and it allows me to learn from them, and it allows me to think like, well, maybe that's something I would be interested in, maybe I can grow in that way as well. I think when I was going through pharmacy school, I spent a lot of time just on my own, reading and studying and very focused in what it is I was interested in, which was psychopharmacology, which is great. It's paid off, it's really great. But I think, if I were to give myself advice coming into undergrad or pharmacy school, I'd really say just broaden your perspective and take an opportunity to go and to get out of your comfort zone and to get some experiences and see how that shapes you. I would say that as a person, I've grown a lot in the past several years because I've had different experiences in my life that I think have really helped me to mature, helped me to become more confident in who I am, and it just helped develop me in different areas. Whereas if I was just on the same path, I probably wouldn't have much growth. But I feel like I've taken some risks and did some additional things in terms of my education, involved myself in some different areas across pharmacy and in the health professions. And some of my research, and I feel like it's involved other people in my life, and those people have really helped me grow a lot and helped me become more confident in who I am. So I think if you can have those experiences early on, I think that's fantastic. That's really what I appreciate in other people, or the diversity that they bring and stuff that I'm just not, never had an experience to, or it's something that's not my comfort level. I always appreciate when somebody brings a new perspective or some diversity to a situation.
Going along those same lines, what are some of your non-pharmacy passions, and how do you balance that with your career?
Yeah, so I have 2 kids, so it's like work and family life, work, back and forth. So when I do get some time to do some stuff on my own, usually I jog a lot, so I run. I try to run, the better part of a number of days throughout a week, so 5 days a week or so. Try to get out and get some exercise. And that's really about it, to be quite honest with you. I mean, it's pretty pathetic. But yeah, so exercising is kind of my thing. That's really. Kids take up a lot of time, and work takes up a lot of time. I used to be into movies, and certainly my wife and I go out to eat. And so we have some time together. We used to go to the movies and museums and all these kinds of things, but the honest truth is that we're just exhausted. So if I can get some running in, I feel like that's an accomplishment. That's some me time. But then, the rest of the stuff is spent, doing things with my kids, or doing things together as a family, which is always, it's new experiences, and it's fun to spend time with them. So.
How old are your kids?
10 and 7, yeah. So they're, developing into their own individual person and their own kind of interests and stuff. So it's kind of neat to go through that again with them and to see what they're excited about. So a lot of it is directed at them. Yeah.
So what are some of the projects that you're involved in right now, and how do they interrelate to your job?
So probably over the past, I don't know, 3 to 4 years or so, I've really kind of shifted to doing more educational-based research. And that even more specifically has come down to developing at Duke, along with some colleagues there, developing an interprofessional course. And this course teaches the students psychiatry and substance use disorders. And so we have really developed this thing over the past 5 years to be more inclusive of other health profession students. So initially when we started out, it was medicine, and it was pharmacy students, and it was PA students. And then we went after and got some social work students involved because they just happened to be at Duke Hospital as well. And then from there we went and got some students from the Duke School of Nursing program. And so we started just adding in new health profession students into the course, and then we started adding in new faculty into the course. So like it was just me and the psychiatrist who were really doing a lot of it. And then we started adding in, we added in some people from the School of Nursing, and we added some folks in from the PA program. We added in an actual nurse who worked on the inpatient psychiatry unit. So we brought all this new energy into the course, and it was really cool. And so we've been working on developing the course, and as part of that, we've been collecting a lot of data off the course as well. And so we've published a couple of papers. We have a couple of papers that have been accepted, which is very exciting for us to have our work get out there and get recognized, because we think we've developed something that's pretty cool in that we're taking students past the level of just like, here's a knowledge or here's an attitudinal change. We're actually taking it to the level to changing behaviors, and one level further in influencing patient outcomes. And so this last iteration of our project really is targeted at, like, we want students to have a better approach to interacting with patients, and that interaction with their patient is them providing counseling to somebody with a substance use disorder. And then the step further from that is then we ask patients a series of questions about what type of behavior change do they want to make now. So like if you're smoking, if tobacco use disorder is your substance use disorder, and you want to quit smoking, one of the questions the student will then ask you is, would you be willing to call the North Carolina Quit Line? Mm-hmm. And then the patient would say, like, no, get out of here. I don't want to talk to you. Like, I'm tired. I don't want to be done. I want to be done with this. Or they'll say, like, yeah, I'd be interested in calling the Quit Line. Or yes, I'd be interested in speaking to somebody about nicotine replacement therapy. And so we took it to that level. So, this is all something called Kirkpatrick's hierarchy of educational outcomes, and we took it to the highest level. And when you look at the educational literature landscape, no one's really doing that. Everybody kind of captures the low-hanging fruits, which are like, I pre-test you on your knowledge, I post-test you on your knowledge improves. You have a really bad attitude, we give you a bunch of education, your attitude improves. So we did all that, but then we also said, like, here are patient outcomes. Mm-hmm. Now, we didn't take it to the furthest step to see if patients actually followed up, but we took it to the level of, like, did the patient agree to do something? Because really, that's a big step for a student, to be able to go to a patient and be comfortable and talk to a patient about their substance use, right. And have that patient actually sit there and listen to them, and actually give them an answer like, yeah, based on what you're telling me, yes, I'm willing to change a behavior. We also taught the students before they did that how to do behavioral change counseling. And we had this nurse who's a phenomenal nurse. He does a great job, and he rounds on our stress management team now at the hospital, but he sat there and provided observation of the students and then gave them real-time feedback. And he is like an expert in behavioral change counseling. So it's been, it's really, been this really cool thing that has just developed over like 5 years. And we just keep bringing in these different elements, and it just keeps gaining momentum and energy and excitement around it. And we're at the point now where we're really just trying to push it out into the world so that other people can see what it is that we've done. So we have some papers, and then we're presenting it at some workshops at different conferences and stuff. So we'll see what the public has to say.
Since today's episode is about psychiatric pharmacy, I wanted to take a moment to talk about an organization that's important to be aware of as both a student and as a practitioner. The North Carolina Physicians Health Program, soon to be known as the North Carolina Professionals Health Program, is an organization that assists individuals who are struggling with mental health, substance use, communication, or burnout issues in the workplace. NCPHP works to connect individuals with services and provide monitoring so that they can advocate for those individuals in front of their prospective licensing boards. NCPHP also offers scholarship opportunities to individuals who cannot afford their services. So if you or someone you know is struggling in the workplace or in the classroom, please reach out to PHP. We will link information in the bio for you to follow if you know someone that can benefit from these services. Thanks for listening.
Hi, and welcome back. We're going to dive a little bit more into what you do on a daily basis and sort of the aspects of your jobs, the challenges that your specialty is facing, and that sort of thing. So,
Okay.
So you talked a little bit about the path to your current position, but so what are the main features of the job that you do clinically, and sort of what makes your practice site unique?
Yeah, so I guess on a day-to-day basis, so I round with what's a medicine psychiatry treatment team, and so Duke is probably like maybe one of a dozen programs across the U.S. that have a medicine psychiatry residency program. And so because of that, we have a medicine psychiatry treatment team or a treatment service. And so we are in the hospital. So we're in the regular old Duke University Hospital, just like any other internal medicine team. But we take patients who have not only both acute medical, but also acute psychiatric issues. And so kind of the day-to-day kind of process for working on this service is that, you know, we all kind of get together in the morning. Usually the learners, so the students and the residents will go in pre-round, as the, you know, like myself and the attending psychiatrist will work up patients on our own. And then we get back together as a team and we sit around and do group rounds, talk about patients, talk about kind of what the plan is, what the treatment plan is for the patient. Oftentimes we'll bring in the caseworker who will talk to us about kind of what the disposition plan is, so where the patient's going after they leave the hospital. And then we'll round and go see patients. And then usually around noon every day, which is the great thing about being at a big academic center, there's some kind of education going on. So we have things like chairs rounds for the psychiatry chair. We have medicine psychiatry conference. There's pharmacy grand rounds. You know, there's all sorts of education every day for at least an hour a day, if not more on some days. And then in the afternoon, it's just really kind of catching up from the morning, you know, making some treatment plan changes and making sure all that stuff's put in before we all head home later in the afternoon. For students, you know, they are kind of really kind of brought right into the team and work together closely with the other learners on the service. So medical students, PA student, psychiatry residents, who is ever rounding on our team, the pharmacy students are integrated right into that treatment team, and they're expected to really be the kind of the ones who are responsible for anything related to medications for those patients. And so, you know, kind of from day one, they are expected to be right involved in the treatment team, not on the fringes, but right involved in the team and helping the team make those medication treatment decisions for our patients. So it's really, I mean, it is one of those services that I find like day to day very interesting. Again, we have some really unique cases and patients present with some really just some interesting presentations, disease presentations. And it is one of those things where we're always kind of like, does anybody know what's going on? Like, has anybody seen this before? Let's go look into the literature. For us on the medication side, you know, it really is less about like, let's choose an antipsychotic or let's choose an antidepressant. It's really like the patient's presenting with this. They have all of this other stuff going on medically, but they also have this depression or they have schizophrenia, and they have a very severe presentation of it. We need to find the drug that is, you know, is perfect for this patient because they've got all of this other stuff that's going on with their health. And so we really have to find a drug that works well, not only for their psychiatric disorder, but also won't destabilize their medical condition or won't interact with their medications that they're receiving. So I think for the students, I think it's really a cool service to be on because, I mean, there's a lot going on. And so not only is it medicine, but it's medicine and psychiatry, so they really have to kind of, you know, get involved in both of those aspects of patient care and really help the team understand what is the best medication. So it moves a little bit from being like guidelines and clinical trials to being like understanding pharmacology and understanding how the drug works and, you know, understand how the drug's mechanism of action may cause it to have certain adverse effects, which could be beneficial for a patient or would be something that we'd rather not expose the patient to. So I think it's a pretty cool service. And then woven in with that throughout the year is the research and the teaching that I do as well. So I really would say, and also on some hospital committees and then stuff here at Campbell with teaching and the committee work down here as well. I mean, there's a lot of variety to the stuff that I do. on a day-to-day, week-to-week, across the year. There's a lot of stuff going on. And I think also that's what's really cool about my position as well. I just got a lot of different things going on, which keeps me interested in the job. And just when I start to think like, I'm tired of being on service, like I come off of service and I pick up my research. And then sometimes I'm like, I'm getting tired of just being by myself in my office. I'd love to be back on service, working with learners, working with patients. Then I go back on, so it's a really cool job. There's a lot of variety to what I do. And a lot of that is me driven because I have so many different interests and I want to explore these different interests, which has been great. And I've been given the freedom to be able to do those kinds of things, which I really do appreciate. And it suits me well for my personality. But it also is something that I would encourage a lot of people to do because, sometimes you get bored at what it is that you do, and being able to be involved in different things helps kind of keep you, keeps you interested in what it is that you're doing, and it expands what it is that you're able to do. So,
what advice would you have for other practitioners that are interested in sort of adding that variety to their careers? Yeah,
I mean, it's tough. I think the position that I have supports it. Mm-hmm. Certainly when I'm not on service, I have time to do research. And I have time to write papers. If I'm not teaching, then I have time to develop my lectures and then go teach and stuff. So it's difficult, but I think the key thing that I always talk to people about is trying to find a team. Like if you want to write a paper, you don't have to be the person that writes that paper. Sure. What you should do is you should really try to find a group of people who are interested and work with those folks to build a team, and together as a team tackle pieces of a project or tackle pieces of a paper. And then together as a team, everybody gets a paper or a project done. And that's kind of when I started out, I was the, new to the hospital, kind of the low person on the totem pole. And I just reached out to other folks that were in psychiatry and in addiction and said, hey, I'm interested in this area. I'm willing to be a worker bee, and I'm willing to help out, but I can't do it myself. I need somebody else to help me, either because I don't have the time to do it, or I need somebody who has more influence at the hospital to be able to do a project. Sure. And everybody's looking for a paper. Yeah. And especially at a big academic center, everybody kind of rates each other based on what they've got going on. And so everybody's looking for a paper or a project to be involved in, but certainly no one has time. I mean, everybody's super busy. And so I think if you could piece it together with a team, and if you have somebody that could be the driver, I think that helps out a lot. I think it's always daunting to think I don't have any time to write a paper, which is true. But you probably have some time to work as part of a team to write a section of a paper. And then maybe there you start to expand it a little bit further. It's always better to do stuff with other folks, so.
So what are some of the challenges that your specialty is facing today?
I think I think psychiatric pharmacy is expanding. I mean, there are residency positions that have opened up. So there are more residency positions that have opened up in the past 5 years than there have ever been. And certainly when I was looking for a psychiatry residency, there were very few. And so I think, there are more positions available to do a second year of residency, but a lot of those positions go unfilled. So I think, general interest of pharmacy students going into psychiatry and going into substance use, I think is, there's always, there's some interest, but there's always not a lot of interest. And it certainly is one of those big things like AmCare or cardiology, or critical care, where a lot of folks are really competing for those residency slots. So I think that's one of the things is who's going to be the next group of people who are going to continue on with this specialty. I think the scope of practice, I don't know that it's really changed much for individuals who practice in psychiatry. I know there's some interest looking at pharmacists' involvement in giving things like long-acting injectables. I know there are states where pharmacists do give injectables. I know North Carolina is a state that's looked at that. There's a lot of push for pharmacists to become more involved with things like Suboxone. Certainly as patients come to pharmacies to get their Suboxone. The naloxone access law and pharmacists being able to dispense out naloxone without an actual prescription under the Good Samaritan Act. So, there's areas where pharmacists can be involved. And so I think those things have expanded, but overall, scope of practice stuff, I don't know that it's expanded that much. And I think that's kind of true for all of pharmacy. Mm-hmm. And the other thing is I don't know what kind of positions are open for individuals who are interested in going into psychiatry. I don't know what those positions are, if there are more of them. It feels to me like there's more interest in having pharmacists being involved in caring for people who have an opioid use disorder, and specifically in the VA system, and pain management. But overall, I don't really know. But I hope there is.
So how do you integrate on the healthcare team that you
Yeah.
are a part of, and what do your colleagues come to you the most for?
Yeah, so I think, and I try to establish this with the students as well, is like we are the people who have the best understanding of how these medications work and how to use these medications in practice. Now as I've been there, going on my 12th year, I have a really good understanding of like all of these different nuances, like patients present with these things or patients have these kind of quirks. I have more experience using these medications in practice, but certainly going into it, I had a lot of knowledge about psychotropic medications, and now I have a lot of experience using them in practice. So I think I integrate well into the treatment team. I think, I'm a well-respected individual and respected for the knowledge that I bring to the service. And I think the expectation is that if there is anything related to medications, if it's like what medication to choose for a patient or like, hey, how come this hospital doesn't stock this drug, everybody kind of comes to me as the person for any questions related to medications for psychiatric or substance use disorders. Which is really neat. So it's a really cool thing to be involved with a treatment team that's, full of really smart people who are dealing with very complex, complicated issues with our patients, but to be somebody that the team turns to say like, hey, we need your help with this medication issue. And then oftentimes I'll turn to the students, and then the pharmacy students are the ones that then become responsible for helping go into the literature or go to the guidelines to really help us understand what's the best treatment for that patient. And so I really feel like we're integrated well into a collaborative team. In psychiatry, substance use disorders is really based on that collaborative approach because it really does take everybody to handle the needs that these patients present with. And when we're talking about patients with psychiatric issues, it's not just like what's the diagnosis and what's the medication, it's like where are they gonna live? And so that's where everybody is involved in this team that provides care for these patients. Because a lot of our patients, different from most medicine patients, they're not going home. A lot of them don't even have a home to go to. They're going to a group home, or they're going to another care facility to have their care continued at that point because they have nowhere else to go. So it really is a collaborative approach, and I really do feel like at a great place like Duke that's has a great reputation, myself and the students are really integrated into the team as the individuals who are responsible for helping the team make treatment decisions. So I think it's a really cool experience for the students to have that, yeah.
So we'll sort of end on this, but what are some drugs that are on the horizon in psychiatry and substance use disorders, and how do you think they might change your practice?
Yeah. So I think, so psychiatry since like the early 50s and with the development of chlorpromazine and the development of antipsychotics over that period of time and antidepressants and again, going back to the early 50s and some of the monoamine oxidase inhibitors and how it's changed to the SSRIs and some of these newer medications that have come around and, benzodiazepines have been around forever. There's been a lot of drug development in psychiatry and some really interesting drugs have been developed over those decades. But then I think it really went stagnant. I mean, as we think about drugs and their mechanism of action, we really have a bunch of me toos. And it's been that way for as long as I can remember, for several, decade or more now. I can't think of like a really novel, unique drug that's come out in the past decade or so. Until now, where we have esketamine, which just got FDA approval for treatment-resistant depression. So that's very exciting. We have some new long-acting injectable antipsychotics that I think are very exciting as a way to help our patients with schizophrenia and bipolar disorder manage their psychiatric disorders, but take away the issue of medication non-adherence, which is a big issue for our patients for a number of different reasons. And then we have this condition called tardive dyskinesia, which is an iatrogenic a side effect that occurs when somebody's on an antipsychotic for at least 3 to 6 months or so. For the longest time, it was irreversible. Once it happened, if you didn't catch it soon enough, it was irreversible and tough luck to the patient. But now we have 2 drugs that actually can be used to treat it. And they have a novel mechanism of action. So I think like those 3 drugs, esketamine is certainly there's a lot of interest in esketamine and its role. for treatment-resistant depression because it works through glutamate and NMDA receptors versus the old serotonin norepinephrine pathways. I think there's a lot of excitement there. It also seems to be some interest in using it in people who are highly suicidal as well, and suicide's become a big issue in the past couple of years too. So, I mean, there's a lot of excitement around ketamine and now S-ketamine as an intranasal formulation. I think some of the new formulations of naloxone are pretty interesting as well, and the intranasal naloxone that's out there. And then, and again, some of these medications that have been developed to treat adverse effects from antipsychotics, I feel like finally it's like we've got some cool things going on in psychiatry, some new drugs that are out there that work in novel ways that whereas for decades it was like dopamine, serotonin, and norepinephrine. Now we've got drugs that work by different mechanisms. So I think it's pretty exciting, and I've heard there's some new drugs that are in the pipeline that have some novel mechanisms of action to treat a number of different psychiatric disorders. So I'm kind of interested to see, what the future holds. But I mean, I think psychiatry's always been this really neat field, and there was the heyday of like when all of these drugs were being developed, and they all had different mechanisms, and then we went from the typicals to the atypical antipsychotics in a big revolution in how these drugs work for schizophrenia. And then again, in the development of the SSRIs, lots and lots of amazing things that happened there. But then it's just, again, it's gone stagnant for, a decade or more. And so now we finally have some new medications out there. So it's pretty exciting.
Yeah. Well, thank you so much for joining us today.
Yeah, thanks for having me.
I think it would be really informative for students. And,
I hope so.
I hope that you guys enjoyed out there. So thanks so much.
So, coming to the end of our third episode, I can't believe we've actually done 3.
I know, another episode in the books.
Yeah.
Another great interview with Dr. Muzyk. Really interesting person.
Yeah, I have to say, I don't know anyone in my class that has read the textbook from front to back, so.
Yeah, both Goodman and Gilman and DePiro. Man, that's pretty impressive. That's pretty impressive. But I would not imagine, if there was one person.
I was about to say, it makes sense for him.
that did it. I couldn't imagine to be anyone else but Dr. Muzyk, for sure.
I also really liked hearing about his research, and that, I think students a lot of times forget that there's other kinds of areas of research besides just the clinical pharmacology, patient care kind of stuff. So it's cool to see about like academic research and what you can do with that.
Yeah, he's been getting into that a lot lately, and I think he's some of his strategies have been very, very interesting as far as like looking at actual outcomes from that perspective. So I'm excited to see what he does with it.
Yeah,
for sure. Well, that's it.
Yeah.
That's the semester's worth of interviews in the books. Again, we do have a link to our survey in the description to help improve our podcast. So make sure you check that out and give us some feedback so we can improve our product. Until then, we'll see you in May for another interview.
bye-bye.